Pedro Martinez Clark, and I'm an interventional cardiologist at the University of Miami, and I'm an assistant professor of medicine. So Mr. Guido Rocha is a patient that we met a few months ago when he was referred to us from the Key West from Dr. Bruce Boros' office. He has severe aortic stenosis, which means that one of his heart valves is severely narrow, and he developed significant symptoms due to his inability to breathe and to perform physical activities due to the barrier that this obstruction or this narrow valve imposes on the heart. So he was referred to us a few months ago for consideration and for further evaluation to see if he was a candidate for aortic valve replacement or any type of new procedure that could be performed on him. So when Guido first arrived here, we have a multidisciplinary team that it's made out of vascular surgeons, heart surgeons, interventional cardiologists, nurses, research personnel, fellows. It's a radiology. It's a very comprehensive and multidisciplinary approach to this condition or to these patients, and that allow us to really understand the complexity of these cases. And after carefully reviewing his case, we determined that his risk for standard aortic valve replacement, in other words, his risk for heart surgery was too high, and that more than likely he will not survive standard operation. So we had to consider newer alternatives to this aortic valve replacement if we wanted to be able to help Guido. After we review Mr. Guido Rocha's case, and we determined that he was not a good candidate for traditional aortic valve replacement, we recommended inclusion into a percutaneous aortic valve trial. We have a program where we implant or replace the aortic valve using minimally invasive techniques or catheter-based techniques that are not surgery, that these are an alternative to surgery, and these are very, very new and advanced percutaneous procedures that allow us to replace the aortic valve without surgery. These procedures are still not FDA approved, and patients have to go a rigorous evaluation. And this is where this multidisciplinary approach and team effort comes into play. After evaluating Guido, we determined that he was a good candidate for a percutaneous aortic valve replacement. Specifically in his situation, we will use what is called a transapical approach. And what this means is that we will make a small incision in the apex of his heart, in other words, under the breast area. We'll make a small incision, and in the cardiac catheterization laboratory using X-ray techniques in catheters, we'll be able to direct and orient ourselves in such way that from this apical approach or incision in the apex of the heart, we'll be able to implant the valve without major cardiovascular operation. If this procedure was not available, if you look at patients that are in Guido's situation, their prognosis is very poor. The only treatment known today to replace or to treat aortic stenosis is by replacing the valve. And the only way to replace this heart valve, at least up until now, is with open heart surgery. If Guido didn't have this option today, or didn't have the option of having a minimally invasive procedure to replace the aortic valve, he wouldn't have any options available. Traditionally, the only way to treat aortic stenosis is by replacing the aortic valve. And the only way to replace the aortic valve is by performing aortic valve surgery. There are patients that will not be able to tolerate a major cardiovascular surgery. And up until now, all those patients will unfortunately die from the consequences of aortic stenosis. And this is why this is so exciting, because now we have alternatives to in treatment options that we can offer to this group of patients. Whereas before, up until a year or two ago, we didn't have any available options for these patients. When we look at this procedure and compare recovery time with aortic valve, traditional aortic valve surgery, there are significant differences in the recovery. I have to say that the recovery from this percutaneous aortic valve procedure varies in the approach that is used. Right now, this percutaneous aortic valve could be implanted in several different, or using several different approaches. One of them is using the femoral arteries, in other words, the arteries in the leg, and placing a catheter in those arteries and delivering the valve in the heart via those catheters that are placed in the aortic valve through the femoral artery. So that procedure, that particular approach has the fastest recovery because it's the easiest, technically perhaps the easiest one to perform. And the recovery for that particular one total for a strong patient might be 4 days, 5 days in the hospital at the most. This other approach that we use is the transapical approach. And the transapical approach is the one that we'll use in Guido's case, and that one includes a small incision in the apex of the heart. And because of the drains that are used and placed after the procedure, the recovery might be a couple of days longer. And then there are other alternative approaches that are available and that are becoming more available, and that we have also that we can also offer to patients that are not good candidates for femoral or transapical approach. A fascinating aspect of in my opinion, a fascinating aspect of the reach that the UHealth system has in the region is the opportunity and the access that we can offer to patients in the entire region to new technology and to all our research programs. To give you an example, Guido lives in Key West, and this procedure is not available in Key West. And he went to see our partner, Bruce Boros, in our office, University of Miami office in Lower Keys, and he immediately recognized what the condition was and had immediate access to a program that can deliver state-of-the-art innovation and technology that is not or will not be otherwise available. With just a simple email or a phone call, the whole team was activated. And that's, in my opinion, that's a fascinating aspect of the entire care that a patient like Guido Rocha will receive.
my name is Dr. Richard Berger, and I'm a clinical cardiologist here at the University of Miami Hospital, and I practice private clinical cardiology, but in addition to that, for many years, I have acted as an integral coordinator for patients in Florida Keys being brought here to the University of Miami. The patient who we're talking about now was brought here with a diagnosis of aortic stenosis. What that means in layman's terminology is that one of the major valves of the heart, the aortic valve, which allows blood to leave the heart, has become blocked. The term we use is stenotic. Most of the time this is treated with surgery, but because of this patient's concurrent conditions, he is not a surgical candidate. The risk of operating on him is significantly more than the yield. And for this reason, he was put into a protocol procedure which has now been utilized for some years with potentially great results, whereas it is unnecessary to open the patient's chest completely to replace the aortic valve. This lessens the risk considerably, and once the valve is replaced, the patient's condition can and usually does improve drastically. When a patient has a significant aortic stenosis or blockage of the aortic valve, the symptoms usually are related to three major areas. Number one, heart failure, which is an accumulation of fluid in the lungs. This causes a significant loss of energy and severe shortness of breath. In addition, the patient may have angina pain or inadequate blood supply to the heart. This pain is very significant and unrelenting and can cause heart attacks where muscle is actually destroyed. And finally, these patients may actually lose consciousness because they're unable to pump adequate blood to the brain, therefore precipitating a sudden loss of consciousness. Some years ago, approximately 4 or 5 years ago, a relationship was established between the University of Miami Hospital and Key West. This began with Dr. Boros and myself, who for many years, more than 20 years, have been integrating our services with Florida Keys. We have provided tertiary care abilities for the Florida Keys. The opportunity came for us to join with a hospital and university such as Miami, whereby we could provide the Florida Keys with all subspecialties available in a prompt way. As you can appreciate, when emergencies occur in the Florida Keys, sometimes, but not all the time, it's necessary to transfer such patients urgently. And we have been able to establish a wonderful relationship whereby patients can be treated promptly. In addition to that, the University of Miami, with its vast resources, transfers these resources availability to the patients in the Florida Keys. In order to coordinate a relationship between the Florida Keys, Key West, or Marathon, and the University of Miami requires excellent communication. That means that someone here at the University of Miami, which in the past has been myself, has to be available 24 hours a day, 7 days a week. They answer the phones for emergencies. Once the phone is answered, the coordination begins here at the university, whereby the proper subspecialists are urgently requested and are made available. If the patient is having, for instance, a heart attack, we're able to get the patient into a helicopter here into Miami with less than 1 hour onto a table. Specifically, the patient who we're talking about now, Mr. Roche, is a gentleman who is an icon in the Florida Keys. I've been privileged to work with him and his family for many years, as has Dr. Boros. He's elderly, but his mind is not elderly. He has a young mind with a tremendous will to live. His symptoms had worsened over the past few years. All of the symptoms that I had previously mentioned related to the closure of his aortic valve. Attempts were made to palliate his situation by doing procedures which buy us time, and he was certainly considered on multiple occasions for surgery. But because of what we refer to as comorbidities, meaning other problems in his body, he is not a good surgical candidate. We, of course, here at the university were very pleased when we were included in the new protocols to allow us to consider him for a percutaneous aortic valve, meaning putting an aortic valve into his body without having to open his chest, using a catheter to do this. Once this became available, we immediately saw the connection between this procedure and our lovely patient who was willing to pursue this, and now he is, as we know, being considered for and will undergo this procedure. Our present situation with our present patient, Guido, of course, opens up the knowledge that patients in Key West need to understand and should understand that we here at the University of Miami are contemporary with multiple different areas of expertise, not only in cardiology, but in all the subspecialties. And what our association with Key West gives the Key West patient is the ability to integrate themselves into these services. And we're not only talking about emergency services, we're talking about services that are less intense and less acute, all of which are available to our Key West patients via the relationship with the University of Miami. Good morning, Guido. Welcome back. I'm sure you'd rather be somewhere else. And of course, we wish that you didn't have to be here, but we're happy to see you again. How are you?
Good morning, Dr. Bird. I feel about fine.
You're feeling pretty good.
Good,
As long as you don't do any heavy activity, you're good, okay?
That's right. Yes,
all right. Now, I know that Dr. Clark and myself have explained to you about this procedure that we're going to do. And although the procedure is considerably less risky than surgery, which we had talked about, there is obviously always a risk, which we've discussed with you and your family. Everybody understands. But you're a young man, and you want to go ahead and live a longer life and a productive life, and something where you can do what you want to do. Am I correct?
Yes, sir. Thanks to you and Dr. Berger.
Dr. Boros.
I'm ready. Dr. Boris.
Yeah.
I'm ready to go.
My older brother, Dr. Boros.
Yes, sir.
He won't admit to that.
I'm ready to go.
Are you feeling okay today?
Yes, sir.
Are there any questions that you'd like to ask me relative to the procedure or how long you're going to be here? Anything you'd like to ask me?
No, sir. You know, I've asked you before,
Yes.
and
Okay.
I've had good answers and good hopes.
Where's the family? Are they here, nearby? They're coming up, your family?
Well, Tony's over here,
Okay.
and my grandson is coming down.
Okay. Listen, I want you to think positively, okay? You've already thought about all the bad things that can happen. It's necessary for you to understand those things. But my advice to you is once you accept them, you just think positively, because we are too.
Well,
We want to send you home and go down and celebrate everything in Key West pretty soon,
I
okay?
try to overthink possible,
I know you do.
and I'm not worried about it.
Okay, buddy boy.
Yes, sir.
All right, I'll see you during the procedure and right afterwards.
All right.
Okay?
Thank you very
Okay,
much.
my friend.
How are you? You doing okay?
I'm doing fine, yes, sir.
Okay, good. Well, today is this is kind of the final step in a long process, and as you know, we've done a lot of work with you over the last few months to try to get you to this point. And what we're going to do today is we're going to place a catheter in the heart just to measure the pressures inside the heart, and that will allow us to understand what the kind of the filling pressures and the volume and status of your heart, because they need to be in optimal situation in preparation for the percutaneous valve replacement tomorrow. And once we have that data, it's a very simple procedure, nothing to be scared of. We'll have that data and we'll adjust the medications and the fluids to make sure that your heart is in the best possible shape for tomorrow. Then tomorrow we'll bring you down early in the morning and we'll do the procedure under general anesthesia. And when you wake up, the procedure will be done. So that's exciting.
Well, I thank you very much. I've been waiting for that.
Yeah, I know. It's great. It's great to have you here.
And I know you guys are great doctors there, so I ain't worried about it.
Well, thank you very much. You have to thank Bruce Boros for.
Oh, yes, my God. Boris, yeah, I got to thank him because he's done so much for me. This is not the only thing he's done.
I know. You guys have a very close relationship, yes. And he was really your advocate here at the the university. So,
Yes, Mr. Berger and Mr.
Richard
I
Berger.
get confused. Mr. Berger's been pretty good for me too. He's helped me a lot down there. And Boris, he's been helping me for 30 or 40 years, I guess.
Well, hopefully everything will be successful. Everything will go well, and then you'll go back to enjoy your life with a lot more strength and ability to do things that you enjoy.
I thank you very much.
Good.
This disease called aortic stenosis, the valve, rather than opening very easily, is very rigid and can't open. It causes an enormous strain on the heart.
Mr. Koppelman suffers from a disease called aortic stenosis, a condition where the valve in his heart has become calcified, making it nearly impossible for his heart to pump blood through his body. A healthy valve, like this one, is flexible and can easily open and allow the heart to pump blood where it is needed. However, Bill Koppelman's heart valve has become calcified and rigid. This is aortic stenosis. They have inserted a guide wire through an artery in his leg and will actually stop his heart for a few seconds to implant a new artificial valve attached to a wire stent.
Large catheter, which is delivered to the spot where the valve sits in the heart. And then with a balloon, the valve is opened and a new device is implanted by that balloon expansion.
The device, only about 1 inch in size, consists of a valve stitched inside a stainless steel frame, which is implanted and held in place by the patient's calcified valve.
This new method goes very, very rapidly, and so basically the heart stops pumping. We kind of create a cardiac arrest, and then we put the new valve in and pull the balloon out.
The stent and balloon must be made the exact size for Mr. Koppelman's aortic valve. Otherwise, when his heart is restarted, the stent and balloon must be made the exact size for Mr. Koppelman's aortic valve. Otherwise, when his heart is restarted, the stent could leak or even come loose, and the procedure would be a failure. Everything has led up to this moment. What happens in the next 15 seconds could be the difference between life or instant death for Mr. Koppelman.
That's it.
The team